One.
Good
We
evening,
are live.
everyone, and welcome to today's webinar on lung cancer update. Without further delay, I would like to invite our first speaker, Dr. M. Santosh Reddy sir, for his talk.
Yeah, hello everyone. I guess I'm audible, right?
Yes, sir.
Yeah, perfect. So let me share my screen. Is it visible?
Yes, sir.
So I'll make it full screen. I guess it'll be okay. Is it okay?
Yes, sir. It is full screen.
Yeah, right. So firstly, I thank AstraZeneca for giving me this opportunity. So without any kind of delay, today I was given a topic of early detection and molecular biomarker testing for therapeutic prediction of the lung cancer. So I'm Dr. Santosh. I'm working as a consultant medical oncologist in Omega Hospitals, Karimnagar. So, as we know, based upon the molecular biomarker, the landscape of the lung cancer treatment has changed drastically in the last decade. So, we'll be discussing step by step. So, how the treatment has been changed, what is the epidemiology of the lung cancer, and so on. So, my talk for today, it covers all these things like epidemiology of lung cancer in India, importance of screening and early detection of the lung cancer, as well as how to diagnose the lung cancer, what are the molecular biomarker testing in the lung cancer, and what is the latest updates on the lung cancer treatment. So, if you talk about lung cancer epidemiology in India, especially, if you talk, it is like fourth overall incidence in India after breast, oral cavity, and cervix, whereas it is the fourth leading cause of mortality. If you see the lung cancer is seen as a death sentence, it is because every year 2 million new people have been diagnosed with lung cancer. Only 1 out of 5 will be alive after the 5 years of the diagnosis. It is such a dreadful disease. So the leading cause of cancer death worldwide is lung cancer. And every minute, if you see the lung cancer, 3 people will be dying of the lung cancer. Around one-fifth of the cancer deaths among all the cancers are from the lung cancer. So definitely it has got a good kind of incidence even in India, as well as it is the leading cause of mortality. There is no surprise when compared to the worldwide. And proportion of patients according to the extent of disease, Indian data if you see, it's not only in India, like in the worldwide even the stage 4 percentage is more common when compared to the stage 1, 2, and 3. If you see in the stage 4, it is 65.9% of the cases we see in stage 4 disease. So almost of all the lung cancer patients have metastatic disease at the time of diagnosis. The 5 year overall survival, if you see, it is obviously will be in the decreasing trend. As the stage increases, the survival decreases. So if you see from the stage 1 to stage 3, it is almost from 92% to 26%. Whereas in stage 4, it is almost completely dropping down to less than 10%. So the overall survival rate reduces with the advancing stage of lung cancer. Early diagnosis is important for the better survival. So if you see for the early diagnosis, what is the importance of screening and early detection in the lung cancer? So we'll see steps in the lung cancer screening process. As we know, based upon the risk assessment, we'll be doing the screening. So in the high risk candidate, we'll be taking an informed decision and we'll be proceeding further screening. What are the high risk? The patients who could receive and the patient who are the smoker, these are the high risk patients. I'll be discussing this about the high risk category also in the coming slides. But if you see the patient who are high risk candidates for the lung cancer screening, so basically we'll be doing the baseline scan as low dose CT scan. It is not the Normal CT scan, what we usually do in the practice, it is low dose CT scans which has a less amount of the radiation. As a result, if we see any kind of nodules or any benign appearances, we have to react based upon that. If you see any nodules in the low dose CT scan, the further investigations as per the screening findings will be following. Whereas if a patient is having any benign appearances, we will guide him to do the low dose CT scan annually. So if you talk about the risk assessment, if a patient is having the smoking history or some kind of radon exposure or occupational exposure, if there is any family history of the lung cancers in the first degree relatives, or the patient is having long-term COPD or any second-hand smoking history. So based upon this, the age 50 years and above, more than 20 pack years of history of cigarette smoking, these are the kind of patients who are considered as the high risk. Whereas the age less than 50 years and less than 20 pack history, these are kind of the low risk. So if you see any kind of patients with a high risk, definitely we'll be advising him for the screening modality with the low dose CT scan. So these kind of patients should undergo a low dose CT scan annually. Whereas in the low risk patients also, we will be recommending for the screening. That is not routinely recommended, but it is good if the patient is okay for doing the routine screening. So the majority of the lung cancer patients, these patients are asymptomatic at the time of diagnosis. So these kind of patients, the lung nodules are incidentally detected. So in one of the study of 665 lung nodules, so 62% of these nodules were incidentally detected. Just because the patient had some kind of trauma or cardiac symptom or any abdominal symptom, these patients have come to the hospital and the lung nodules are detected incidentally. So 15% were found in patients with symptoms attributable to lung cancer. It means that major chunk of the patients will be asymptomatic and only 15% of the patients will be symptomatic. 13% were identified in patients who qualified for annual low dose CT scan. So out of 70,000 odd patients with incidental lung nodule finding prior to the implementation of low dose screening, 44% were never smokers. It means not only the smokers, even non-smokers also can be having the lung cancer. So incidentally, lung nodules management can help to increase the screening rates in early stages. So if we nowadays artificial intelligence is coming the big way. So artificial intelligence has been assisting radiologically how to diagnose a lung cancer so early. So we have a number of index publications plus 50 index publications. So there in artificial intelligence, how these artificial intelligence will help in catching up the early lung cancer nodule so that we can diagnose the lung cancer so early. So if you talk about two brains are better than one brain, right? So that is why with the help of artificial intelligence, there is rapidly evolving to screen these kind of patients and to get catch hold of these patients very early so that we can increase the outcome. So after having the discussion on the screening, now we will be talking about how to diagnose of lung cancer. If we see how the lung cancer patient will present, as we know, lung cancer patients will be having persistent cough and hemoptysis, as well as the hoarseness or wheezing, along with fatigue and weight loss. So there can be some kind of shortness of breath and loss of appetite. So if you see the stepwise approach in how to diagnose these kind of patients, so if you see, we'll be doing the clinical and examination. After the clinical examination, the laboratory examinations like common blood cultures and the medical history and the performance status will be taken into account. And these patients, if it have symptomatic, if there is suspicious marks in the lung on the low dose CT or in any kind of X-ray, we'll be further proceeding with further investigations. So the further investigation like imaging modality, it can be, we'll be starting with the chest X-ray, simple chest X-ray. If you have any doubt on that, we'll go with the chest CT or the whole body PET CT for the metastatic workup. So it is which kind of lung cancer. So it depends upon the pathology. So whether we will be doing the biopsy from the EBUS or from the CT guided biopsy or the thoracosynthesis or mediastinoscopy or mediastinotomy. So all these kind of indications will be coming in the patient, like it depends upon the location of the tumor and what kind of modality will be good for the patient so that we can get a good chunk of the tumor tissue for the further investigations. After the biopsy, we'll be sending the tissue for the histology, as we'll be coming to know whether it is non-squamous or small cell variety. So based upon that, we'll be deciding whether to send for the molecular testing if appropriate. So every case of the lung cancer is different. Every individual patient is different. So better to discuss all the cases in MDT in the lung oncology, which we will be doing in our real world practice. So the MDT in the lung oncology, it consists of all the people like medical oncologist, radiation oncologist, the surgeon, as well as the radiology and oncopathologist and pulmonologist. Whereas the palliative health care team will also be included in this MDT because from the day one, we'll be starting the palliative healthcare team help we need. So multiple evaluations are performed to diagnose and determine the stage of the lung cancer. So after the aim of the diagnosis is to establish whether the cancer is there or not and what is the extent and stage of the disease so that the appropriate treatment can be planned for the patient. So the patient with warning signs and symptoms of lung cancer were misdiagnosed as tuberculosis. In the real world, even in 2026, majority of the patients who come from tier 2 and tier 3 cities, these people will be going to the local rural doctor and they will be misdiagnosed as TB and empirically they will be starting on TB drugs. So after finishing 2 to 3 months of treatment on MDT treatment, these patients won't respond to this MDT and they'll be coming to the tier 1 or the tier 2 with a good medical oncologist. So these patients, after coming to the after having the duration of 3 to 4 months delay in the treatment, these kind of patients they will be rapidly having the disease progression and in majority of the times will be having the metastatic setting. So these patients are being misdiagnosed as tuberculosis among in 20% of patients. So what is the importance of molecular biomarker testing in lung cancer? Uh, so if you see, the majority of the patients, like 55% will be adenocarcinoma and 34% will be squamous. So all these oncogenic drivers are mutually exclusive in majority of the times, with only 1 to 3% of NSCLC cases exhibit concurrent alterations. So adenocarcinoma, if you see, unknown mutations 31, the major chunk is from the KRAS, it is 25. EGFR is 15%, whereas ALK is 7%. And the rest follows like BRAF, RET, and NTRK. Whereas in the squamous also, the PIK3CA is 0.33, whereas FGFR1 is 22, whereas BRAF is 0.02. MET amplification is in 0.05%. So additional biomarkers for NSCLC, not only with these biomarkers, we'll be also testing the PDL1 testing. It has number of platforms like Ventana, SP162 or SP263 Ventana or 22C3 FarmDX. So any kind of PDL1 will be depend upon the which kind of immunotherapy drug you are be using. And tumor mutation burden, it also aids us in deciding which immunotherapy drug to give, whether the patient will be benefiting on the immunotherapy drug or not. So based upon this, now we have the histology, and after the histology, we'll be testing upon the molecular. In the molecular testing, will adenocarcinoma stage 4 or as per se any kind of stage in adenocarcinoma, we have to do a molecular testing for sure. Whereas in the squamous, if you talk about non-smokers and female, these kind of patients will also be undergoing molecular diagnostic testing. So this lung cancer diagnostics have evolved to cater to the transformation mutation specific treatment regime. So based upon the which kind of mutation the patient has, we can target that. So what is the good? These are the multiple methods available to detect NSCLC biomarker for therapy. It depends upon the patient financial status, whether we can have only IHC, PCR, FISH, or directly with the NGS. In majority of the times, now NGS is so affordable. It's not like before, which is like cost effective. Now, majority of the patients are undergoing NGS. With we have multiple coupons for that. So, majority of the patient will be having NGS. The patient who even after not affordable for the NGS, we can have the IHC for the EGFR, whereas FISH and ALK, FISH for the ALK fusions. So, so what is a good diagnostic tech should be? It should be accurate. It should be quick and simple. It should be accessible to all the patients and relatively cheap, which is much more important, and require a minimal amount of tissue. Always a tissue will be an issue for the pathologist. So definitely we have to guide our radiologist to take multiple chunks of tissue if possible, so that one tissue will be sent for the histopathology, other tissue for the NGS. So identification of predictive biomarkers has led to the paradigm shift in lung cancer diagnosis. If you see, the biomarker testing has been increasing gradually from the patient from the last decade and is now emerging for resectable NSCLC also. As I said before, for all the adenocarcinoma patients, irrespective of the stage, we will be doing biomarker testing because there is an adjuvant role of tyrosine kinase inhibitors even in the adjuvant setting. So biomarker testing to identify patients most likely to respond to target therapies and immunotherapy. Single gene testing like PCR, FISH, and IHC are gradually being replaced by the NGS. As I said, NGS is much more affordable nowadays. So if you talk from way back from 2000, where we used to do only the IHCs or FISH, but nowadays in 2021 to 2026, we have drastically improved from the IHCs and FISH to the NGS in majority of our patients. So as the landscape has going on from the molecular pathology perspective, the treatment perspective also has changed drastically in the lung cancer. If you see what are the actionable biomarkers in NSCLC. So first, at least the majority of the times, we'll be expecting the EGFR, ALK, ROS, MET, and BRAF, at least in the first line setting. Whereas in the second line, we can have the HER2 and KRAS. So if you talk about the metastatic setting, per se, if you talk the molecular markers like EGFR, ALK, ROS, these kind of things should be tested so that we can target these kind of mutations. So if at all the patient will be divided into driver positive or driver negative. If at all patient is having driver negative, we have to target which is actionable. If at all patient is having driver negative, we'll be uh, testing the PDL1. So it depends upon whether the PDL1 is high or in term like one more than 1 to 49 or less than 1. So we'll be deciding the immunotherapy based upon the PDL1 score. If the PDL1 is more than 50%, single agent immunotherapy would suffice, whereas the PDL1 1 to 49, we have to combine immunotherapy along with the chemotherapy. Whereas PDL1 less than 1%, we have to combine immunotherapy along with the chemotherapy or double immunotherapy plus chemotherapy. IO plus chemotherapy. Whereas if the patient is having driver oncogene positive, we have to target these kind of genes, whichever is positive. So if you talk about EGFR positive or ALK positive, we have plethora of options nowadays, like first generation, second generation, and third generation drugs. So if you see target therapies, first, when we never used to have the targets or when we never used to test these kind of EGFR, we used to give the age-old chemotherapies like in the squamous histology, we used to give paclitaxel carboplatin, whereas in adenocarcinoma, we used to give pemetrexed and carboplatin. So these kind of patients at that time, whereas in, I guess like 8 to 10 years back, the survival was around 6 to 8 months hardly. But nowadays, if you target these kind of genes, we can expect a survival. You can see down the survival 8 to 12 months, and flora you can see 38.6 months. So it depends. See how the magic of immunotherapy and target therapy has done. So the EGFR, if we have a wonderful drug called as osimertinib, whereas for ALK we have a wonderful drugs like lorlatinib and alectinib. So ROS also we can target with the crizotinib. So not only about the target therapies, even if you see about the immunotherapies, so we have plethora of options of immunotherapy like pembrolizumab, atezolizumab, nivolumab, and cemiplimab. So all this number of plethora of options are available. It depends upon the PDL1 score. As PDL1, as we know, it is not a good great marker, but we usually do in the real world practice. PDL1, if it is more than 50%, single agent immunotherapy would suffice, where we can expect a survival of 30 months in PDL1 more than 50%. So what is target therapy? So target therapy, it identifies particular cancer target gene which we can exactly hit and get the good benefit, it attacks or inhibits that target specifically. It stops the cancer cell growth and kills it. So how to identify the target in the cancer cell? By doing the molecular testing of cancer tissue or in some kind of blood test based. Which are targets identified in lung cancer cell? 50% of patients of lung cancer can have targetable mutations. So in my practice, if I test 100 patients, almost 35 to 40% of my patients are being targeted. So in patients with metastatic lung adenocarcinoma, EGFR are the most common of the oncogenic drivers that are targetable. As you know, EGFR percentage is more. These patients are being targeted with third generation EGFR tyrosine kinase inhibitors like osimertinib. Nowadays, osimertinib has a median progression-free survival of 18 months, which used to be before with only chemotherapy of around 6 to 8 months. So almost it has doubled. So the overall survival, if you see, with the newer generation of target therapies, further it highlights the need of molecular testing. If a patient is having EGFR exon 19 del or L858R, if you see based upon the FLORA trial, of overall survival in EGFR positive patients, if you see even after the 4 to 5 years, the patient is been exceptional responding. The median OS is 38.6 months, whereas the comparator is 31.8. Mm, it has still increased in the uh, newer data. Whereas Alex trial, if you see overall survival in ALK rearranged patients, it is hazard ratio of 0.76. Comparison with alectinib versus crizotinib. So coming to the immunotherapies, if you see the immunotherapy, the PDL1, which rests on the tumor cell, whereas the PD1, which is there on the antigen presenting cell, that is T cell. So the binding of PD1 with the PDL1, so it forms a it binds and then uh, the drug enters into the cell and it kills. So we have plethora of options of immunotherapy nowadays. So we can target these kind of uh, of patients with the immunotherapy. It depends upon the PDL1 scoring. So if you see, if a patient is having adenocarcinoma and EGFR mutation positive, we can give osimertinib alone or the osimertinib plus the chemotherapy based upon the FLORA2. Or we can even try with the second generation CKI patients who are not affordable. And we have the Indian data of EGFR mutation positive exon 19 del from the TMH. Even we can try with the chemotherapy plus the first generation with the Geftinib. Even it has shown a good benefit. The all positive patients, we can give alectinib or brigatinib, or we can also even give the third generation like lorlatinib. ROS1, we can give entrectinib, BRAF V600E, we can include dabrafenib like trametinib or vemurafenib. MET exon 14 skipping positive patients, we have vision trial, capmatinib and tepotinib. So geometry for the capotinib and tepotinib for vision trial. So red positive patients, we can give selpercatinib and NTRK, larotrectinib. The PDL1 positive patients, I have already discussed before. We have atizo, we have cemiplimab, we have uh, durvalumab and nivolumab nowadays. So coming to the conclusion of my uh, today's topic, so the implementing incidental lung nodule management with lung cancer screening programs are complementary and can achieve stage shift towards earlier disease. So the diagnosis will determine the specific management strategies for the lung cancer cases. The biomarker testing in NSCLC has evolved from single gene to multiplex testing. New method like next generation sequencing show immense promise for the future. NSCLC management is driven by the molecular testing. Biomarker test results should be obtained before treatment decision if clinically feasible. That's it, I guess, and thank you.
Thank you, Doctor, for your valuable insights. Moving ahead, I would like to invite Dr. Arif Khan, sir, for his talk. Over to you, sir.
Yeah, good evening, everyone. I'm trying to share my screen. I hope they are visible. Slides are visible.
Yes.
So thank you, Roche, for the opportunity. Today I will be discussing about one trial which has made a huge difference in the in such a subgroup of patients with advanced lung cancer patients who are old and frail and who are not fit for the standard treatment options. So the mutation negative PD-L1 negative patients who are old and frail with compromised organ reserves. So these patients are not fit for any standard therapy, and we encounter these patients in our practice quite frequently. And the options which are available are like single agent chemotherapy, and this chemotherapy, though it improves the survival to some extent, but it is not the treatment which we are willing to offer for these patients. And even the immunotherapy, there are some drugs which have improved the outcomes, but it has compromised the quality of life of these patients. And this Tecentriq has come up with one trial in this subgroup of patients where it has proven that even in this subgroup of patients, the old, frail, and platinum ineligible patients, we can offer the immunotherapy, and it has proved that this immunotherapy has improved the outcomes even in this frail subgroup of patients. These are the disclaimers. So as Santosh has already described that in India, the lung cancer is the fourth most common cancer, and it is one of the leading causes of cancer death. It accounts for around 85% of all lung cancers, the non-small cell lung cancers, and majority, as we know, that they're present in advanced stage. So either stage 3 or stage 4, and most of them are not in a curable setting. This is what I was talking about, that in real world settings, around 40% of patients of advanced lung cancer are either frail, have very poor performance status, or substantial comorbidities. So the standard treatment options cannot be offered for these patients. The platinum doublet along with immuno or these standard options are not possible for these patients. So these patients are excluded from standard phase 3 randomized trials. So the poor performance status and with multiple comorbidities with affected organ reserves, these patients are not included in standard randomized trials. If we go to the global data, non-small cell lung cancer is usually diagnosed in advanced age. So it's the age cutoff according to global data for any lung cancer patient is around 70 years. In India, age at which they present is 63 years. So these patients, because of their age, they already have poor performance status, they are frail, and also they have multiple comorbidities, and the organ functions are not adequate. So they are not eligible for platinum doublet chemo. So what are the basic factors which we consider when we decide the treatment for a lung cancer? So one is the histology, that is very important. So based on the non-squamous, and adeno and non-small cell, small cell, we decide the treatment based on histology, and also the PD-L1 expression also plays an important role. That higher the PD-L1, better is the response and outcome with the immunotherapy. The other factors which we consider while deciding the treatment is performance status. So this is also an important factor. So any patient having PS more than 2, he will not tolerate the treatment. If the patient doesn't tolerate the treatment, the outcome is severely compromised. So we don't get the benefit of survival which we expect and also because of the compromised performance status. The comorbidities also play important role while we decide the treatment. So suppose the patient has compromised organ functions, these patients we can't offer the standard platinum doublet chemotherapy. Age, as we know, it goes almost with the age is a very important deciding factor, because more the age, more the comorbidities, and the patient is also not fit. The patient is frail and has some or the other comorbidities associated with the age. And other factors are the social factors. So what the guidelines recommend in those patients who are frail, old, and with poor performance status is either single agent chemotherapy, and the data for single agent immunotherapy is very sparse. So there's insufficient data to suggest irrespective of the PD-L1 to offer immunotherapy in such patients. So the main reasons, according to one study here, the MOONOS trial, to avoid platinum was age was one of the deciding factor. The other was comorbidities. The other was the performance status. The minority of the factors was the family and social issues. So these were the main factors which were considered the main reasons for the patient to label as platinum eligible or platinum ineligible. These are the standard contraindications for the platinum chemo. So for cisplatin, usually we take into consideration the age. If it is more than 75, cisplatin should not be offered in these patients. PS more than 1 is again a strict no for cisplatin chemo. Renal function, if it's compromised, creatinine clearance less than 60 is again a contraindication for using cisplatin. Heart failure. So any NYHA class more than 1 heart failure is a contraindication for cisplatin. The other is uncontrolled hypertension, pre-existent neuropathy, maybe because of the diabetes. So cisplatin can worsen the neuropathy. And also the elderly age patients already have some form of hearing impairment. And this also is one of the contraindication for using, though not an absolute, but a relative contraindication for using cisplatin. For carboplatin, again, it's age more than 80 years, PS more than 2, and creatine clearance, though we take the cutoff for avoiding carboplatin as less than 45, and severe heart failure. So anything more than grade 2 heart failure is considered a contraindication for carboplatin. For single agent chemo, there is no age cutoff. We can offer single agent chemo at any age, provided the patient is fit. And the PS more than 2 is again, it falls into that gray zone that whether we should be offering some chemo or not, because again, chemo, though it improves the outcomes to some extent, it can compromise the quality of life. So the quality of life is severely compromised with chemotherapy. It can have side effects, and the patients can become more, actually the performance status deteriorates with the start of chemotherapy. Renal function, again, it's not an contraindication for many of the chemotherapies. And heart failure is a contraindication because the affected heart, compromised heart function is a contraindication for single agent chemotherapy. These are the outcomes which we see with the use of single agent chemotherapy in platinum ineligible patients. So with gemcitabine, according to this phase 2 trial, the survival which was seen was around 9.8 months. So vinorelbine, it's around 7 months. Docetaxel, it's around 5 months. And pemetrexed, if you use single agent pemetrexed, we know that pemetrexed is the most common chemotherapy agent which we use in adenoCA. So with single agent pemetrexed, what we can expect in this platinum ineligible patients is the median OS is just 4.7 months. Is almost similar to the placebo. So there is a huge unmet need in these patients, the old frail patients with compromised organ functions. What should be the treatment of choice? So there are some trials with immunotherapy, single agent immunotherapy, Pembro here, Pepsi 2. It was a single arm trial, phase 2, which enrolled all these platinum ineligible old frail patients, regardless of the PD-L1 expression. 60 patients were enrolled, and around 24 patients were first line. So the median OS which was seen in this study was around 8 months. The PFS was around 4.3 months. So NIVO-EP was also, it was a phase 3 study which tried to enroll these old frail patients, but the treatment, this study was halted prematurely because of the high mortality. So the median OS was very dismal in this study with the NIVO-EP. It was just 2.9 months. Durvalumab, again, they tried to include this patient phase 2 trial with all those old frail patients having PD-L1 score of more than 25%. But this study was also stopped prematurely because of increased fatal events, and the further enrollment was stopped. So today I'm going to discuss this study, this important study in this subset of patients who are considered platinum ineligible, who do not have any meaningful treatment options. And this study addressed those subgroup of patients. So it was Ipsos was a phase 3 global trial. It was multicentric and it was open label, and it was a randomized study. Indian patients were also included in this study. It was atezo versus single agent chemo, though in those patients who are considered unsuitable for platinum doublet chemo. So some Indian centers also contributed to this study here, like Tata Memorial Hospital was also active. The contribution from the Indian center. So this what background, what we know that the first line treatment of non-small cell lung cancer with chemoimmunotherapy has improved survival as compared to only chemo. There is no doubt in that. We have many robust studies to suggest that immuno, when added to chemo, it improves the survival. And single agent immuno, we know that as Santosh was telling, we in PD-L1 high more than 50%, we can expect a median survival of close to 30 months. So that is how but these trials did not enroll those platinum ineligible patients. And as I discussed before, that 40% of patients in our setting, in our real world setting, have poor performance status, and they are elderly, and they are having multiple comorbidities, and we know that they are not fit for chemotherapy. These patients already have limited treatment options because they don't have that mutation driven cancers, and also they have poor performance status. So Ipsos, coming to the study design, it enrolled all treatment naive stage 3-4 non-small cell lung cancer patients, either squamous or non-squamous. So both histologies of non-small cell were included. All platinum ineligible patients because of the poor performance status. If the PS was good, more than 70 years of age was also allowed in this study, and they were mutation negative. Some of the patients had asymptomatic brain metastasis. So patient with brain metastasis were permitted. So pretty large study, 450 odd patients. It was a randomization between atezo versus single agent chemo based on the physician's choice, and the treatment was continued till loss of benefit or progressive disease. And the stratification factors were used. There was the histology, squamous versus non-squamous, and also based on the PD-L1 expression level. The primary endpoint was overall survival. The secondary endpoints were the OS at various time intervals, the progression-free survival, objective response rates, duration of response, and the OS and PFS in PD-L1 positive subgroup. The other measures which are quite important is the quality of life and safety measures. So these are very important to test, and also though the drug can achieve the similar outcome to the chemo, but it should preserve the quality of life. That's what we are going to look into in this trial. And as we can see, the baseline characteristics are well matched. It's a pretty balanced study. Majority of patients were between 70 to 79 years of age, and 75% of patients in both arms had ECOG of 2, and Asian population constituted around 25% of patients in both the arms, and almost squamous, non-squamous are almost equivalent here, and brain mets patients were only minority of patients, just 9% of patients in both the arms, and 75% of patients had the PD-L1 score less than 50%. Coming to the overall survival at the final analysis in intent to treat population, so there was a meaningful improvement in the overall survival, which was statistically significant. We can see these curves. So at 3 months, some overlap was seen, and later on the curves got separated. And we can see at 1 year, the delta for OS was 5%. The 5% improvement in the overall survival at 1 year, that was a secondary endpoint. And at 24 months, the overall survival, the delta got bigger here. So it was 12% improvement in the overall survival. Even we can see the benefit of survival with atezo as compared to chemo was maintained even at the tail of the curves, showing the benefit. So the immuno here, atezo, is showing a prolonged benefit, and it is improving the survival for a longer time as compared to chemotherapy. The median OS, though the delta is not so good, but we can see here the various time intervals, the delta was quite good. And end of 2 years to get the 12% difference in the survival we can say it's almost the findings are robust and very practice changing here. Hazard ratio 0.78 and p-value quite significant 0.2. Subgroup analysis of OS here, all subgroups benefited with the treatment. We can see irrespective of the age, gender, race, Asians had a good hazard ratio here, and even the squamous, non-squamous equally benefited, and those patients having PD-L1 score of more than 1 or more than 50, so almost the benefit in OS was similar. PFS, again, initial overlap of curves. It started we know that immunotherapy takes time to act. So initial, we see that on all the immunotherapy trials that it takes the initial, there will be overlap of the curves. Later on, the curves start separating. And at end of 1 year, it was 5% difference in the PFS, and 24 months, it was 7%, 7 point to be exact, 7.3% improvement in the PFS. So the median PFS, though numerically not so lucrative or not so attractive, but there was the delta got bigger and bigger with the prolonged follow-up, and even the tail of curves are showing that PFS benefit. There were also improvement in the responses. The overall responses were better in atezo as compared to chemo. Duration of response also better, 14 versus 7.8 months. Disease control rates were almost similar between atezo and chemo. Coming to this important analysis of quality of life, so with the patients on atezo arm remained stable across all domains. There was no deterioration in the quality of life for a longer period in atezo as compared to chemo. So across all the function, role function, social function, and cognitive function, it preserved the quality of life. So that is so it improved the survival, it improved the responses, and also it preserved the quality of life for a longer period of time as compared to chemotherapy. Even the symptomatic improvement was seen with atezo here. The curve there was improvement seen. Even the peripheral neuropathy, there was not much deterioration in the immunotherapy, and the other symptoms like chest pain or all were well controlled on atezo as compared to chemotherapy. Again, this chest pain was that symptom control was to the maximum here with atezo as compared to chemotherapy. Coming to adverse events here, the grade 3 for adverse events were lesser in atezo as compared to chemo. So 16, almost double the risk of side effects with chemotherapy as compared to immunotherapy. So the disease discontinuation rates were almost similar between the two arms, 13%. Coming to immune-related adverse events, as expected, the grade 3 adverse events were marginally higher with atezo as compared to chemotherapy. So the Ipsos study included nearly 76% of patients who ECOG PS2, as we have seen in the baseline characteristics, and more than 73% of patients were more than 70 years. And among them, 31% of patients were more than 80 years. Even in such old, frail patients, this immunotherapy worked. Atezo improved the survival responses, and also it maintained the quality of life. So this is Ipsos regimen is again recommended by the NCCN as a option for all those PS3 patients, regardless of PD-L1 expression. Even the ESMO guidelines recommend atezo monotherapy as for all platinum ineligible patients who have poor performance status and who are old and with multiple comorbidities. So as we have seen that first line atezo monotherapy significantly improves the OS as compared to the single agent chemo. Those subgroup of patients were platinum ineligible and platinum doublet ineligible, and the benefit was seen across all subgroups, irrespective of the age, PD-L1 status, and histology. The OS rate was almost doubled at 2 years with atezo, 24 versus 12%. The responses were also higher with atezo as compared, and they were more durable with atezo as compared to chemo. It maintained the quality of life, and there was significant improvement in the symptoms. The time to deterioration of chest pain was significant with atezo as compared to chemo, and the adverse events were seen in lesser number of patients as compared to chemotherapy, and there were no new safety signals. So single agent atezo, the monotherapy should be considered in all the old frail patients who have compromised organ functions are the first line treatment of choice in mutation negative non-small cell lung cancers. So with this, I conclude my talk here and I hand over to the organizers. Thank you.
Thank you, Doctor, for your valuable insights. Last but not the least, I would like to invite Dr. Sanat Kandim sir for his talk. Over to you, sir.
Thank you for the kind introduction, and I would like to thank organizers for providing me this opportunity. So I think my slides are visible and I am
Yes, sir.
audible.
Yes, sir.
Sure. So today my talk will be the age-old drug like chemotherapy, which role, though reduced in the first line, definitely we use in the practical setting in the second line and third line setting. So role of bevacizumab in non-small cell lung cancer, one of the oldest target therapy we can say. So this session is sponsored by Dr. Reddy's Laboratory. I would like to thank them. So coming to the foundations of non-small cell lung cancer and treatment context. So as explained by earlier speakers, lung cancer is the most common cancer leading to the mortality, cancer-related mortality. Previously, it used to be the most common cancer in the world. Now, prostate cancer has crossed it. In India, if you see the incidence, so it is the second most common cancer in the males. And in India, there is a shift from the histology. That is previously it used to be small cell, then squamous. Now it is the adenocarcinoma. One of the main reason is the filtration of the cigarettes. And as explained by the previous speakers, so 80%, 80 to 90% of the lung cancers present in stage 4, only 5 to 10% in the stage 3. Rarely we see stage 1 and stage 2 lung cancer that we have increased during the COVID season. So as explained, most of them will receive ATT previously and there will not be any response. Then they come to the specialist. So there is a multiple reasons for the delay in diagnosis. And coming to the molecular profile, so nowadays, so molecular profile, if you don't do molecular profiling in a lung cancer, then we can say it's a crime. So at least minimum to minimum EGFR all cross should be done because it completely changes the prognosis and prediction to the treatment. So EGFR all cross and PDL1, these are the minimum test to do. And role of anti-angiogenic therapy, so like bevacizumab, so how it acts, how it enhances the chemotherapy, immunotherapy or TK. So it can be combined with chemotherapy, immunotherapy and TK. So risk factors, so we have seen 90% of the lung cancers are because of smoking. But paradoxically, only 10% of smokers will get lung cancer. This is the paradox. And genetic inheritance is very rare. And most commonly, the age is 60 to 80 years. And therapeutic advances, many therapeutic advances are there from the age-old chemotherapy, then target therapies like anti-VEGFs, then TKIs, then immunotherapies. Now we are using BiTEs. So it has progressed to till that. So tumor biology and rationale for anti-angiogenic therapy. So tumor biology is important anywhere because biology is king. However hard we try, cancers like, for example, triple negative breast cancer, pancreatic cancer, gallbladder, biliary cancers, and small cell lung cancer. So they will have worst prognosis. Even the patient is fit, even we are giving a high cost drug, so the prognosis will be bad. So in any time and anywhere, so biology is the king. We have to believe it. And P53 is the just a second, sorry. P53 is the we know it is the father of tumor suppressor gene, but its mutation can lead to bad prognosis. And these are about the mutations. So coming to the angiogenesis and hypoxia. So whenever there is hypoxia, it stimulates the VEGF release and increase in the blood vessel growth, which leads to micromets and metastasis. So tumor microenvironment and EMT, epithelial mesenchymal transition is most important. That is the first step for the metastasis. So drugs which act at the tumor microenvironment are the like bevacizumab, cyclophosphamide, eribulin. So these alter the tumor microenvironment. And mainly, what does these anti-angiogenic drugs do? So anti-VEGFs or TKAs. So they do alter the blood vessels. So multiple collateral blood vessels were transformed into linear blood vessels. So so that the blood supply will be increased to the tumors and enhance the chemotherapy effectiveness. Whenever there is increase in blood supply, chemotherapy will reach better and chemotherapy will act better and there will not be hypoxia. So there will not be excess angiogenesis. So this is the mechanism behind the anti-angiogenesis. So role of angiogenesis in non-small cell lung cancer. So VEGF-A, main receptor, main pro-angiogenic ligand stimulating vessel formation, promotes tumor growth and metastasis. HIF-1 alpha, which has great role in the RCC. So we have drugs for HIF-1 alpha inhibitors for von Hippel-Lindau syndrome, drives angiogenic switch in tumors, abnormal vessels. So as I explained, leaky, disorganized vessels, which are converted into non-leaky organized vasculature, and endothelial proliferation, formation of new blood vessels, which increases the metastasis. So bevacizumab mechanism, evidence, and clinical application. So bevacizumab is a monoclonal antibody, and so it binds the VEGF receptor and inhibits the ligand VEGF to bind it. So thereby it inhibits the endothelial vascularization or angiogenesis. And what are the uses in non-small cell? It is so it is in upfront. It is used in the adenocarcinoma along with platinum chemotherapy. So we cannot use the bevacizumab in squamous cell lung cancer because squamous is more prone for bleeding. Bevacizumab can cause bleeding as a side effect, and it, as discussed, it increases the tumor vascularization. So guidelines supported are NCCN and ESMO. Not only in the first line, we can combine it with the TKI like erlotinib, and we can use in the second line like chemotherapy plus bevacizumab, or we can use with the ABCP regime. So bevacizumab we can use in first, second line or third line, or we can combine it with chemotherapy, TKI or immunotherapy. So with all of them, it has synergic action. So established combination regimes. So Bev is combined with paclitaxel carboplatin. It is a first line for adenocarcinoma, and there is a synergy between chemotherapy and bevacizumab, and also bevacizumab plus checkpoint inhibitors, bevacizumab plus TK. But careful patient selection. Though serious side effects are very rare with bevacizumab, we usually give not only non-small cell, we commonly give in the colorectal carcinoma. So where the side effects can be bleeding risk, epistaxis is one of the common side effect, and hypertension. That's why we have to measure blood pressure, and nephrotoxicity, nephrotic syndrome, urinary proteinuria, and rare side effects are massive bleeding, IC bleed, thrombosis, poor wound healing. So these are the side effects of bevacizumab. Coming to the clinical trials of bevacizumab in the non-small cell lung cancer. So ECOG 4599 trial. So it has improved progression-free survival and overall survival when it combined with the chemotherapy. So objective response rates are also better. So whenever we want response rates and the patient is not affordable for the immunotherapy, then we can think of bevacizumab. Or whenever patient has contraindication for immunotherapy, like post-transplant case, or patient is on active steroids. So there we cannot use immunotherapy, and when the target mutations are negative, then we have to depend upon chemotherapy. In that places we can use bevacizumab, and bevacizumab we can use in the second line and third line setting also. So survival, so overall survival improvement is there, progression-free survival improvement is there, though the magnitude is less, but definitely there is improvement, and objective response rates are also better. So bevacizumab can be combined with chemotherapy, paclicarbo in the first line. Nowadays we rarely use, because most of the times if it is target mutation positive, then we depend upon the TK, if target mutation negative, then we are giving chemo plus IO. But when there are contraindications to IO, then we can use bevacizumab. When the patient cannot afford IO, or when the patient because of any reason cannot take the IO, then definitely bevacizumab is one of the choice. So trial data summary, endpoint, median overall survival 3 months extra, and median progression-free survival around 3 months extra. Response rates around 20% more are there. Coming to the safety profile, so bevacizumab, whenever we give the patient on we give bevacizumab, we have to monitor blood pressure, and ideally we have to discuss this hypertension side effect with the patient, and patient has to monitor blood pressure at least twice a week, and CUE if required, and less but serious side effects are thromboembolic events. Both arterial and venous thromboembolism can occur, and whenever there is a PICC line or chemopod, the risk increases, and gastrointestinal perforation, fistula formation, which is more important in cervical cancer, and as I discussed, bevacizumab is contraindicated in whenever there is bleed, recent major bleeding or squamous cell carcinoma, we cannot give bevacizumab. So clinical evidence, guidelines, and summary. ECOG 494599 and AVL trials showed that bevacizumab with chemotherapy increased progression-free survival, overall survival in non-small cell lung cancer. And one of the important thing about the bevacizumab is very well tolerable. So we rarely see any serious side effects with bevacizumab, though there are there, but the serious side effects are rare. Like we can say like immunotherapy, but we have to consciously look after it, and we have to discuss with the patient about the bevacizumab side effects. And in the second line also, whenever patient cannot take immunotherapy, we usually give bevacizumab with combination with the chemotherapy, or in the second line we can combine with the ABCP regime. So this is about the bevacizumab, and all the guidelines they mention about the bevacizumab, NCCN or ESMO. So, but its role is becoming less because of the more targetable drugs like TKS in the EGFR all cross positive, whereas immunotherapy in the target negative patients. But it has definitely role in other cancers like ovarian cancer, colon cancer, and in non-small cell lung cancer also. Thank you.
Thank you, Doctor, for your valuable insights. With that, we conclude today's session, and thank you everyone for being a part of this informative webinar. Thank you so much.